Hello and welcome to another live Google Hangout. I'm Dr. Jay Harness, Medical Director at Breast Cancer Answers. And you know, we always have such interesting hangouts here, and today is no exception. We're going to be talking about molecular breast imaging, MBI. Good grief, Dr. Michael O'Connor. Welcome from the Mayo Clinic, and we're going to be talking with you about what is molecular breast imaging. Michael, welcome.
Thank you very much. Delighted to be here.
Yeah, well, tell our audience a little bit about yourself. You've been at the Mayo Clinic for quite a while, and you're a PhD, nuclear med kind of guy. Tell us about yourself.
Well, I've been at Mayo since 1986. Came here straight from Dublin, Ireland, so it was a bit of a culture shock, to say the least. And I've been working primarily in nuclear medicine all that time. And this particular project started way back in 2002 when I managed to get hold of a new technology at the time, a semiconductor-based gamma camera technology that I thought was very intriguing. And this whole project really started from that interaction with GE, who had this prototype, and they said, well, we've kind of finished playing with it. Do you want to play? And I said, sure. So we started work on that. And that's been 13 years ago.
Oh, very good. Now, a lot of our audience, you and I are familiar, of course, with the term nuclear medicine. But our lay audience who will be watching this Google Hangout, and particularly as it's posted at YouTube, probably don't have a clue what nuclear medicine is. Why don't we explain? Let's go to the real basics here.
Okay, back to the basics here.
What is nuclear medicine?
Well, nuclear medicine is very different from your conventional imaging techniques. When you think of medical imaging, you think of CT scans and X-rays. In nuclear medicine, we kind of turn that technology upside down a little bit, in that instead of looking at the anatomy and structure of the body, we're looking at the function of the body. So what we do is we usually inject a small radio tracer that will go to different parts of the body depending upon what organ we're studying. So, for example, if we want to look at the brain, we have a compound we can inject that will be extracted by the brain tissue, and we can image the function of the brain, not the anatomy of the brain, but the function of the brain. So we're taking that concept now, and we're going to use it for breast imaging, where we can take a compound that when we inject into the body gets taken up by tumor cells. So we're going to look at the function of the tissue and not the anatomy of the tissue. So nuclear medicine will let us see these functioning cells in the body. It doesn't tell us anything about the anatomy whatsoever. So, for example, nowadays, a lot of people may be familiar with PET scans, like PET-CT technology, which is a combination of the function from a PET scan with the anatomy from the CT. And MBI is a functional scan that kind of complements mammography in that it shows the function of the tissue, but not the anatomy.
Oh, that's excellent. So people probably, maybe through the years, have had a thyroid scan, or they may have had a heart scan, or your analogy of the PET scan is really perfect. So that we're clear with our audience, this is a radioactive material, isn't it?
Correct, yes. The compound that we've been using for molecular breast imaging is technetium labeled ceftobiprole. It actually was developed in the 1980s for cardiac imaging. Right. And they found, just by happenstance, that it's also taken up in a variety of tumors. In fact, we use it routinely in nuclear medicine for parathyroid imaging and looking at parathyroid adenomas. And people found that it got taken up in breast tumors, and this is way back in the late 1980s. So they tried a technique, and they called it scintigraphy mammography way back then. And they tried to use nuclear medicine to image breast tumors with this compound. And what they found was that they could image the tumors, but they could only detect large tumors. In other words, tumors larger than about 15 millimeters. And that's, you know, at that point, most times you can palpate these large tumors. So the value of the technology really wasn't there because it couldn't detect small 5 to 10 millimeter lesions.
Yeah, now, Michael, the concept here is, and let's explain this to our audience a little bit, that cancer cells, the metabolism of the cancer cells is more active than the surrounding cells. Is that a fair statement? Is that kind of how does it work? In other words, why do cancer cells functionally take up the isotope and maybe normal cells don't?
Sorry, Jay, just lost you there for a moment. Could you just repeat that last comment?
Yeah, hopefully I'm coming through all right. Let's explain how um, the physiology works. In other words, cancer cells are metabolically, metabolism-wise, a little more active than normal cells, and therefore I think they take up the radioactive isotope. Is that a fair statement?
That's a reasonable statement, and it will depend upon the type of tracer that we're using. So in the case of sestamibbe, there are two mechanisms by which it's taken up in cancer cells. One is that as a cancer grows, it develops additional blood vessels to feed the tumor. So you get angiogenesis and increased blood flow to the tumor. And sestamibbe will be taken up because of increased blood flow. And the second thing that happens with sestamibbe, as you get increased mitochondrial activity, as some of the cells, their mitochondria increase in number and activity, that sestamibbe will localize in those mitochondria. So that's why, by the way, it actually works for the heart, because the heart's got a lot of mitochondria in it. But that's also why it gets taken up in tumors. So it's kind of a twofold process. One is the increased blood flow, and the second is the increased mitochondrial activity in the cancer cells. And both of those will contribute to increased uptake of the sestamibbe in the tumor relative to the adjacent normal tissue.
Yeah, in other words, and we see this with breast MRI as well, Michael, that when we give a tracer, if you will, not radioactive, but when we give the tracer we do an MRI, a lot of the lighting up phenomenon in MRI is because, as you said, angiogenesis. Let me define that word for our audience. That means the cancer is creating new blood vessels. It needs more blood vessels to grow. And also those cells are more active, therefore more mitochondria. So basically the technology, so let's go further down the way. This sounds like it was sort of serendipitous, if you will, that you found that breast cancers would take it up. Mayo Clinic has been the pioneer in really refining this technology. Michael, lead us down the road a little bit farther and how this has evolved.
So one of the problems with the old technique of scintigraphy mammography was that it couldn't detect small tumors. And if you're in the game of breast cancer screening, it's very important that you be able to reliably detect lesions in, say, the 5 to 10 millimeter range. Right. Now, the reason that conventional nuclear medicine equipment, these gamma cameras that we use in nuclear medicine, the reason why they could not detect small lesions is that you physically cannot position the breast close to the gamma camera without also allowing the gamma camera to see the rest of the body. And when it sees the rest of the body, it sees all this other activity that's in other parts of the body from your injection, and it corrupts the image or destroys the image. So what we needed was a different type of gamma camera technology that would allow us to image the breast sort of like you do in mammography, independent of the rest of the body. And that's what happened back in the early 2000s. There was this development of a new technology called semiconductor-based gamma cameras, or CCT. Cadmium zinc telluride is a very exotic material, and it has very nice characteristics that allow you to make a very, very small, compact, lightweight detector. And we got our hands on that in about 2002, 2003. We began to make our first system with that. And that we found we could image the breast very like we do mammography, but without the compression force. We just need enough light compression to keep the breast from shifting during the time we acquire the images. So it's essentially pain-free. And we could acquire the images, as you see on the slide there, you can see the breast being positioned. So it's very like a mammography type setup, but without the discomfort of the high compression forces that they use in mammography. And because these detectors are so compact, we can see most of the breast tissue. We lose a few millimeters near the chest wall, but this is way, way better than what we could see with our older technology. The other key thing about nuclear medicine is that the best image quality is when the object you're imaging is right close to the face of the gamma camera. And with this technology...
Let me interrupt you for a second here. So the lady in blue is the dark blue is the technologist on the slide I've got.
Yep.
I think people can read, and the lady whose back is toward us, of course, is the patient. We're not showing her breast. And then you've got these two horizontal panels. These are basically these very, very sophisticated cameras. Is that correct?
That's correct, yes.
And then over, right above the head of the technologist, what is that round, what is that object hanging up there?
That's a lead counterbalance.
Oh,
So it
okay.
doesn't do anything.
Okay. And then the reason for the big circle here that I'm trying to show and share my screen, what's the reason for this big round circle here?
That's basically what they have done. Actually, there's two vendors that manufacture molecular breast imaging systems. And in both cases, what they have done is they've taken mammography gantries and modified them to hold these small gamma cameras. So what you're seeing there was an old mammography gantry that's been adapted for molecular breast imaging. And the reason for the ring is so that ring can rotate, so you can obtain views in different orientations.
Okay, very good. And then the patient here is standing. And then how long does it take, Michael, to acquire? I'm going to show some images here in just a minute. Patients are used to mammograms taking just a few seconds to acquire, but my guess is this may take a few minutes to actually acquire an image. Is that correct?
Correct. Actually, our patients are always seated for this procedure. It doesn't show you that on the slide.
Yeah.
It typically takes about 10 minutes per picture, and maybe a little bit less than that nowadays with some of the newer advancements, but about 5 to 10 minutes would be typical. And since we take 4 pictures, that's a 20 to 40-minute procedure. So we usually have a little iPad, and the patient can go and watch an episode of Friends or watch the news, or whatever they want to do while the images are being acquired.
Well, very good. And now what I put up on share my screen is on the left, a typical mammogram showing a 20-millimeter cancer. And here we've got it on the right. Hopefully you're seeing this all right with my pointer. The actual camera itself, but whoa, here's now an additional 10-millimeter lesion. So let's explain, Michael, to our audience a couple of things. One, why is this better than, obviously, mammograms? And I think you've highlighted that already because we're talking about function here, not anatomy. And then, obviously, in this dense breast, the ability to pick up, in this case, a second lesion. Do you want to share some explanation with us?
Yes, this is the problem with mammography is that a lot of cancers can hide in dense breast tissue. It's not, I don't think, as well understood and as well known as we think it is, because we work in the field. We think everybody knows this, but a lot of women don't realize that having dense breast tissue is a big hindrance to mammography. There are actually two things. One, there's a lot of data indicating that having dense tissue increases your risk of breast cancer, but more importantly, what it does do is masks the presence of cancer. So the dense tissue will look like, has the same whiteness as a tumor does, and it makes it very difficult for the radiologist to detect that cancer in the middle of the dense tissue. Now, about 40% of women have dense breast tissue. So that's a sizable percentage of the population that undergoes screening and mammography have dense tissue where tumors can hide, if you like, inside that tissue and be very, very difficult to see in mammography. Now,
yeah, you can see on this mammogram, this is an obvious density here in the actual mammogram on the left. And this is looking at the breast from the side. This is called the MLL view. And then over here, it really lights up. But down in this other dense tissue, at least mammographically, you don't see anything, but voila, you see things here. My guess is that the second smaller lesions can then be found in ultrasound when you know where to go to look for them. Would that be a fair statement?
That would be fair. In most of the cases, when we find a positive finding on MBI, but it's negative on mammography, it can be found with focused ultrasound. There are a few cases where we have not been able to find it with either mammography or focused ultrasound, but we can find it always on MRI.
Okay. And let me ask you this. So what's the difference then between MRI and this technology, Michael? What can we share with our audience is the difference?
Well, there are, obviously the technology is very, very different, but in terms of the detection rate, we keep saying this, if an MRI cost $100 and was quick to do, we wouldn't be developing MBI. MRI is probably the best technique for detecting breast cancer that's out there, but it's expensive. It's not a pleasant procedure for some patients if you're claustrophobic. People don't like getting into the magnet. But having said all of that, it is undoubtedly the best, the most sensitive tool that we have today for detecting breast cancer. From our own data, we know that MBI will be almost as good as MRI, but not quite as good. There are limits to its resolving power, so we can detect tumors in the 5 to 10 millimeter range. Once we go down to 2 or 3 millimeters, we don't have the resolving power to detect very, very small lesions that may be possible to detect on MRI. So MRI will be a little bit better than molecular breast imaging in that sense. The advantage of molecular breast imaging is it's got very good specificity, which means that we get very few false positives. And that's a disadvantage of MRI because it's a more difficult procedure to interpret, and it tends to have more false positives than MBI does.
Yeah, and that's what we were talking about earlier. I think one of the reasons for the false positives is the fact that MRI is seeing this angiogenesis, this increased number of blood vessels, and we know that benign things can do that besides cancer, where here, with the MBI technology, particularly at the cell level with the mitochondria, the chance of having a false positive, if you will, sounds to me like it's pretty low.
Well, we will still see some. I mean, there's no perfect test, unfortunately. We will see some uptake. For example, some fibroadenomas or papillomas will take up the sesame. So there are occasional false positives with MBI, but when we looked at our studies, the recall rate for MBI was very low. It's actually lower than that of mammography, and substantially lower than that of MRI. So yes, there are some, but no test, unfortunately, is perfect.
Yeah, listen, I'm with you. It's a combination of technologies. Now, Michael, one of the big issues right now in states around the United States is increasing legislation for breast density. In other words, here in California, if we have increased breast density, we're to be advising patients that they should probably consider additional screening. Tell me how you see MBI becoming a part of the screening of patients with dense breasts.
So Minnesota has gone through the same thing you've gone in California. The legislation was passed, I believe, last year in August or September. It went into effect. And actually, that was a very interesting process because it triggered within Mayo, one of our specialty councils on breast cancer convened a committee to look at what would Mayo recommend for patients for supplemental screening. And that committee was composed of radiologists and physicians who work in the breast clinic and breast surgeons and the full range of people who specialize in breast disease. And their recommendation, which came out, I think it was late December, early January, was that within the Mayo enterprise, the only supplemental technique that is being offered is molecular breast imaging.
Wow.
Now that's quite a big step, but again, we do have the benefit of having worked with this technology for 10 years in 2 large screening trials. So our radiologists are very comfortable with it, and they like it. It's easy to interpret, it's quick to do, the patients like it. And so it was a pretty obvious step for us to go forward and say this is the technology that the Mayo enterprise is going to embrace as its supplemental screening option.
Wow, that's a major statement. I think all of us in the world of medicine consider the Mayo Clinic one of the real gold standards in our world. Michael, one of the concerns about this technology has been the amount of radiation that goes elsewhere in the body. And I think some of the original studies were up at, what, the 14, 16 millicurie level. Then you were able to lower the dose down to 8 millicuries. I think you're working on a trial now down to 4 millicuries to help minimize the exposure elsewhere in the body to radiation. Can you share with our audience where we are on that and where you see that going?
Right, so let me step back 1 second and just give a kind of a primer for people on radiation and radiation exposure. So to give you a kind of a benchmark level, if you live in Minnesota, your annual exposure from natural background radiation is about 3 millisieverts. So we use this unit of millisieverts to give you the exposure to the entire body. So that's use that as your kind of your reference level. If you live in Denver, it's 4.5 millisieverts. If you live up in the mountains, it could be up to 10 millisieverts. So worldwide, the range is 2 to 10 millisieverts. So that's our bandwidth for naturally occurring background radiation. So now let's take a mammogram, for example. A mammogram gives a radiation dose only to the breast, but we can convert that dose to the effective dose as if you were to irradiate the entire body. And that turns out to be about 0.5 millisievert. So the difference between living in Minnesota and Denver is 3 mammograms a year. So it's a very easy, and people worry about getting the radiation from a mammogram. We're going, seriously? You wouldn't mind living in Denver, but you worry about this radiation from the mammogram. And tomosynthesis is a little more than that, but the two combined together are about 1 to 1.5 millisieverts, still less than your natural background radiation. MBI right now is in the 1.2 to 1.8 millisievert range, so it's slightly more than the mammogram and the tomosynthesis. It's well below natural background radiation levels, and so we basically had to look at this and say, well, we believe this is now such a low risk, and the benefits are so great that the benefits will far outweigh the risks in our mind. So at this point, in terms of the doses that we're giving, we're in the 4 to 8 millicurie range, actually 4 to 6.5 from the last study. So we can do it at 4 millicuries and 10 minutes per view, or a larger dose and a shorter time. And we've had that debate internally as where should we be with it. We've actually asked patients. We've done patients at the 4 millicurie dose. We've done patients at the 8 millicurie dose and asked them which would they prefer. And the answer is they like what they had. They don't seem to care. So we're going, okay, it's no longer an issue. Patients are far more concerned about the fact, do I have breast cancer or not? And the fact that MBI can detect it so well, I think overwhelms the other concerns that have come up.
Well, Michael, it just strikes me this technology should be everywhere. Why don't you think more facilities have this technology? Do you think the reason is because it's been emerging and you all have been working on it? What do you see as the future for this technology?
Well, that's a very interesting debate as to why a technology takes so long to move from bench to bedside. And there was a paper that came out a year or two ago talking about the length of time it takes to bring a evolutionary technology from bench to bedside, and that's about 5 to 10 years. If you're looking at disruptive technology, and this is disruptive because it's, in a sense, it's very, very new for breast clinics. They're accustomed to mammography, so going to tomosynthesis is very easy. They know what to expect. When you bring in a nuclear medicine technique like this, it's a disruptive technology, and that takes about 15 to 20 years to work its way in. You'll have the early adopters, but a lot of people will sit on the sidelines and say, well, let me just see how this goes before we go and jump in. So even though the results are very good, they're waiting for someone else to take that leap in and demonstrate that it truly does work. So we've had that benefit at Mayo, where we've had all this experience with the technology. So we've leapt in head first and embraced it fully. But for a lot of other clinics, I think they'll sit at the sidelines a little longer, looking to say, is this what we want to do? There are the early adopters, but it's going to take a few more years before it really does disseminate throughout the country and into the smaller clinics.
Yeah, and particularly you do have to have access to the radioactive isotope, either your own lab on site or easy access to it. And I think that's become less and less of a problem. Well, Michael O'Connor, as we wrap this up, any final thoughts you'd like to share with our audience?
Well, I think this is, from our perspective, this has been a major change in how we practice here. We've looked at this technology, and we think that this is just the beginning of the molecular imaging world. In other words, this is an old radiopharmaceutical. There are other compounds out there, but like everything else, nobody's going to jump in until they first see that there is a market for this technology. As MBI becomes better established, you'll see better radiopharmaceuticals, better technology, even lower doses, and better ways of detecting breast cancer. So I think it's just the beginning of a new era for molecular imaging of the breast, and I think it's a very exciting time for us.
Well, this has just absolutely been a fascinating Google Hangout. I must tell you, as a guy who's been focused on breast cancer for 30 years, the headline from today has been that the Mayo Clinic enterprise has decided that MBI is going to be the supplemental imaging technology in women with dense breasts and what have you. So this has been huge. And on behalf of Breast Cancer Answers, Dr. Michael O'Connor, I want to thank you for being with us today. You're a fantastic, articulate guy, and we really appreciate your being here. To our audience, we hope that you've really enjoyed this broadcast. Please join us at our next live Google Hangout. Thank you again for the privilege of your time. Have a wonderful day.
Thank you.